Good afternoon, and welcome to today's Internal Medicine Grand Rounds. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk, and if you're attending virtually, you may enter your question into the chat section. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Sandus Khan. Dr. Khan is from Edmonton, Alberta. She went to University of Alberta, where she graduated with a major in biological science. She then attended the Royal College of Surgeons in Ireland and graduated in 2022. She has an interest in critical care and pulmonology and is pursuing a PCCM fellowship. Join me in welcoming Dr. Khan.
Okay, hello everyone. My name is Sandus Khan. I'm one of the internal medicine PGY3 residents. And welcome to my grand rounds. What is pulmonary rehabilitation? I have no disclosures to report. And before we begin, this is a COPD discharge order set taken from EPIC, which is also interestingly my QI project here at Northeast Georgia Medical Center. Before we begin discussing pulmonary rehab, how many people here have taken care of or seen a patient with a chronic lung disease of any sort? Everybody, yeah. How many people have seen or know about this order set? Okay. And how many people have referred patients to pulmonary rehab? Okay. And how many people know what happens in pulmonary rehab once you refer them? Yeah, so as predicted, less hands go up. So my learning objective is to define what pulmonary rehab is, to describe the various components of pulmonary rehab, and to analyze the goals, the benefits, and the research behind it. So defining pulmonary rehabilitation. A joint statement from American Thoracic Society and European Respiratory Society defines pulmonary rehab as a comprehensive intervention that is based on thorough patient assessment followed by patient-tailored therapies that include and are not limited to exercise training, education, behavior change, and it's designed to improve physical and psychological conditions of people with chronic respiratory diseases and then promote long-term adherence to health-enhancing behaviors. So a lot of words stand out, such as comprehensive, it's an intervention, it's patient-tailored, and it's designed to improve conditions. So broad therapeutic concept, it is evidence-based, and there is a multidisciplinary integrative approach to patient care. And both societies acknowledge this as a core component for care for these patients who have chronic lung diseases. So it's evidence-based, we follow evidence-based medicine, then why do we not use this treatment? So it's underused, under-resourced, and kind of give the numbers, less than 5% of patients with COPD who can benefit from pulmonary rehab receive pulmonary rehab. And even when you offer them, 50% will not take up the offer. So when I initially sent in my first draft for Dr. Umana, who's my mentor, to review, she asked me an interesting question. She said, what are the referral rates in different settings? Because mine focused mostly on hospital rates. She said, surely like ambulatory clinics or pulmonology clinics, those are the ones that are referring the patients. So she asked me to look into them. And the reason why I didn't have that data initially is because there's very little data that exists. Globally, pulmonary rehab is available to less than 3% of patients who can benefit from it. And there was a review done in 2018 about 10 developed countries, and its referral rates are less than 35%. And even 59% of the US counties do not even have a program to refer patients to. And across Canada, access is available to 0.4% of patients. In UK in 2017, they did a survey to see where the referrals are coming from. And then 16% of COPD patients out of 82,000 received referral from their PCP. And interestingly, women are 8% less likely to get referred. And the people who are more likely to get referred are patients who are depressed, have a recent exacerbation, or have been ex-smokers. The ex-smokers were found to have 41% higher chance of getting pulmonary rehab, more than current smokers. And then what about pulmonologists? Like, they should be an expert in this field, but in US, they did a survey of 154 pulmonologists. 61 did not have any knowledge about what the recommendations for pulmonary rehab or what pulmonary rehab consists of. In contrast, just to look, pulmonary rehab offers rates of reducing readmissions by 56% if given early after hospital discharge. A systematic review was done to see why the barriers or the uptake is so low, and 48 reports. 70% said environmental barriers, so such as availability of your programs, like rural areas are less likely to have programs available, and then challenges to traveling to PR centers. And then 38% reported barriers of lack of knowledge of healthcare providers, and then that kind of transitions to lack of patient awareness of the program and its benefits, and then which is 31% of patients who don't have enough information. And then competing health and time priorities, like these patients might be hospitalized and they cannot complete the programs. Or if they're divorced, widowed, or living alone, they're less likely to enroll. And one of the things I want to tackle with the grand round today is the insufficient healthcare provider knowledge that we can influence, because it does not only reduce referral rates, but it can also hinder uptake of the program. Because let's say we say, this may or may not help you, I don't know if I should refer you, or there's negative association with the words rehab, then the next provider that does come to refer this patient to the program, the patient might not uptake it because of the previous interaction they had. So Northeast Georgia Health System offers pulmonary rehab and Gainesville Brazelton. However, it's bolded, entry into the program requires a referral from a physician. So greater knowledge about proven benefits about pulmonary rehab, understanding the process can lead to more referrals and then more people getting the treatment they need. Kind of quickly touching base on chronic respiratory diseases. It's the third leading cause of death, responsible for 4 million deaths, and 450 million people live with chronic lung disease of some sort. And then although looking at this, the data between the 1990s into 2019, the death has decreased and the DALYs have improved. There's still a significant cause for burden of death worldwide. So improvements are needed for both preventative, diagnostic, and treatment options. So aims of pulmonary rehab: you want to improve patients' symptoms that they experience day to day, restore their functional capabilities, make them more independent, and overall enhance their quality of life. So who should get pulmonary rehab? Well, any symptomatic patient that has a chronic respiratory disease that is impacting their quality of life. So it sounds about like everyone who's diagnosed with a pulmonology disorder. But there are official ATS guidelines that was published in 2023 that outlines various conditions such as COPD, ILD, hypertension. But I'll come back to these ones later in the presentation. But most of the evidence comes from COPD patients and COPD research. Who cannot get pulmonary rehab? Patients with chronic respiratory diseases tend to have more comorbidities. They have functional disabilities at baseline. They can have uncontrolled cardiac diseases, severe arthritis, osteoporosis. And osteoporosis is known to have a poor outcome, neurological impairment, cognitive or social disorders. And then, interestingly, if you have coronary artery disease, that does not prevent you from being part of pulmonary rehab. But although if they have cardiac disease, they may be better suited for cardiac rehab. So just keep that in mind. And what do you want to know before your patient starts pulmonary rehab? You want to assess for severity of impairment, exercise tolerance, other comorbidities, and cognitive or psychosocial factors, especially motivation. Motivation is important for them to complete this program. And then what do you want to obtain? You want to obtain pre-participation PFTs, the diffusing capacity of carbon monoxide, and various exercise capacity tests. And these are to basically get a baseline to see if your program helped them or not. Dyspnea, like what is it? It's a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. Ultimately, that means physical activity leads to unpleasant, frightening symptoms, and then this leads to decreased physical activity, which then leads to deconditioning. So further physical activity is prevented, and this becomes a vicious cycle, leading to more disabilities. How do you measure dyspnea? So you have your modified Borg scale. It's a 10-point scale of various symptoms, and then patient kind of just select a point what they think they're feeling at that time. And then the modified Medical Research Council scale, it's 5 statements, and then the patient selects which one is the closest to their situation. Both scales, easy to apply, easy to perform, and they're capable of detecting subjective changes in people's sense of how short of breath they feel, and it also assesses for severity of their impairment. So I have a quick question here. A 64-year-old patient admitted for COPD exacerbation is getting ready for discharge. So on the floors, what quick and easy tests do you do to understand their degree of disability before their discharge? A, VQ scan, D-dimer, 6-minute walk test, cardiopulmonary exercise testing. If anyone just shout out. C. So your favorite 6-minute walk test. I'm sure we all have done it on floors. So how do you test for exercise capacity? 6-minute walk test is one of them. Then you also have shuttle walk test, cardiopulmonary exercise testing. 6-minute walk test, it's walk as far as you can in 6 minutes. And the entire time they're monitored for total distance walked, oxygen saturation during the walk, and the degree of dyspnea they feel. And then what is relevant, like how do we know it's improved? Any increase of 35 meters or more is considered significant for that patient. And systematic analysis of 4 trials measuring before and after pulmonary rehab, to just give a context, most patients report a mean improvement of 107 meters. So that's significant. Shuttle walk test. This is just walking between 2 cones and using progressive speed or using the constant speed, but just giving them more of a push. And then analysis of 2 trials have shown that it improves walk test by 81 meters for this particular test. Cardiopulmonary exercise testing, the most comprehensive, you use a cycloaerometer or a treadmill, and then you measure the physiological outcomes, which includes oxygen uptake, carbon dioxide output, tidal volume, minute ventilation. You do ECG, pulse ox, so it's more complete measurement, but it's usually reserved for those you can't figure out if the dyspnea is from a cardiac standpoint, pulmonary standpoint, or for research. So less likely done. This is the referral form for NGHS. This is what they fill out. The important thing to note is that to the best of my knowledge, this patient is motivated to participate. So it's not just referring them and moving on with your day. You need to know that they will go ahead and complete the program. So getting started with pulmonary rehab, who makes up the team? The team consists of pulmonologists, geriatricians, physiotherapists, occupational therapists, nurses, nutritionists, exercise physiologists, respiratory therapist, psychologist, and pharmacist. So a lot of people involved. It's an integration of various services, and all of this is to improve coordinated care. Where can we do this? We can do this in the hospital, in outpatient basis or home basis. And the number of sessions will change based on where you're doing it from. Outpatients usually 2 to 3 times a week, inpatient 5 days a week. And then outpatient sessions are usually the ones we have most research from. And then again, you're also limited by what's available in your region. And then web-based and telemedicine options are now more promising after COVID. So during hospitalization, you can initiate it after an acute exacerbation. So while your patient is here and before discharge. And then this, although aerobic exercises or their strength might not be fully there, so it could be limited, you can still do resistive muscle training. And this has shown to improve muscle strength and 6-minute walk test outcomes. So what about ICU? what if the patient comes and they're having acute respiratory failure? Do we start pulmonary rehab then? So a study was done in 2014 of a randomized controlled trial about early rehab versus late in the hospital setting. There was no significant difference between early or usual pulmonary rehab. Health hazard ratio was 1.1 with p-value of 0.4, but there was an increased mortality for those who did early ICU pulmonary rehab. So p-value of 0.03. So from this, they have determined that it may be best to wait until the patient is stable to maximize the benefits. How long is one pulmonary rehab program? We don't know. There's not enough research on it. But longer programs, we would think more benefit. So minimum of 8 weeks is advised. And improvements seem to stabilize after 12 weeks. So now most programs tend to be 8 to 12 weeks. Completion, what is completion of pulmonary rehab? It's either you finish your end rehab assessment or you have completed 70% of the sessions. And it's reported 10 to 32% of people who even start pulmonary rehab will not complete the program. Why is that? If they're currently smoking, they're already short of breath at baseline, they're in the hospital most of the time, a shorter distance walked in a 6-mile walk test, a longer duration of the program, or a longer journey to the program itself. Another question, your 56-year-old COPD patient is exercising away at her pulmonary rehab program you have referred her to. What SpO2 is acceptable for her before you make her stop her session? 98, 92, 78, 88. You can guess. It's actually greater than 88%, so you can tolerate that. So when you're monitoring them during the pulmonary rehab session, you're looking for shortness of breath, breath sounds, if they're diaphoretic, if the blood pressure is going up or down, and their SpO2. You can add oxygen to maintain their stats. As long as the stats above 88, you can continue the session fine. And if you have patients with diabetes, you monitor their blood glucose levels because you want to prevent hypoglycemia. And you have to stop your session if they have severe dyspnea, they have chest pain, lightheadedness, tachycardia, hypotension, or refractory hypoxemia. And then another one, true or false, maintenance pulmonary rehab program is having a mortality benefit after you complete initial pulmonary rehab. So basically, once you completed the 8 or 12-week program, should they continue once a week program? How many people think true? It has a mortality benefit. False? Yeah. So yeah, benefits of pulmonary rehab diminish over 6 to 12 months. And then randomized control trial looking at 143 patients to see if a maintenance program is helpful. They noted that all improved after the initial 8-week program, And then there were some improvements noted in their other measurements, such as Bode Index 6-month for up to 2 years, but after that, the benefit vanished, and there was no difference in mortality at 3 years' time. So the answer is false. And what our program consists of at NGHS is we have the initial one, which is the phase 2, they call it phase 2 here, up to 9 weeks of pulmonary rehab. And then some people can opt for phase 3, which is the maintenance option. So components of our program. So exercise, training, patient education, promoting healthy behavior in the patients, and psychological support. Exercise training. So patients in chronic respiratory disease aren't able to exercise. Why is that? That's multifactorial. I mean, there is ventilatory limitations. The requirements for them is higher than expected. They have high increased work of breathing. They have increased dead space, and they have deconditioning, which leads to gas transfer abnormalities and hypoxemia. And all of this works to intensify their perception of dyspnea when they're working, so they prevent exercise. And then cardiac limitations. Some chronic respiratory diseases lead to heart failure, and then tachyarrhythmias, which further prevent them from working. And then limb dysfunction, like lactic acidosis, for example, the burning sensation, the deconditioning from the disease itself, and then a recurrent steroid use, and then further anxiety and fear. So what options do we have? We have endurance training, interval training, resistance training. Those are the three main ones, but you have other options as well. The one that's least studied is flexibility training because it's shown to improve some posture benefits, but really it's not studied. So it's there, and combinations of these can be used. And for any reason, if you need to use like bronchodilators during the therapy, oxygen during the therapy, you're able to do that. Endurance training, which is also called conditioning, you use upper arm or lower legs to train continuously, exercise 20 to 30 minutes, which leads to skeletal muscle adaptation. Lower extremities are more studied because they're easier to measure. And then upper extremity training also leads to improvements in conduction of household tasks. So for example, they can dress themselves, bathe themselves, get strength there. And interestingly, it's noted that some of the benefits come from reduction in exercise-induced lactic acidosis. So a higher intensity overall leads to later of development of less lactic acidosis. So, and which allows patient to perceive less dyspnea, and it increases their exercise tolerance over time. Interval training, it's when you have high intensity exercise with periods of rest or lower intensity. And a randomized controlled trial comparing interval training with continuous training for COPD patients shows that they have similar total work amount, similar results, similar benefits. So it could be given to patients who are less likely to tolerate a full continuous exercise regime. Resistance training, strength training, they have an additive benefit to endurance training, but should not be recommended alone. And you select the weights and the regimen for the patient based on their capacity. And then it leads to improved muscle mass and strength. Breathing retraining. Patients with chronic respiratory diseases have rapid shallow breathing, and then that leads to increased dead space ventilation and air trapping. So you retrain them through pursed lip breathing or diaphragmatic breathing. And then yoga. Yoga has shown to improve 6-mile walk test, but really nothing else, like no results in dyspnea and health-related quality of life. But that can also be because there's not enough studies on it. Some other things that can be done is ventilatory muscle training. So what happens in chronic respiratory disease is this hyperinflation, which leads to a shortened and flattened diaphragm. So it reduces the pressure generating capacity of the diaphragm itself. So you can use these muscle training devices to target the diaphragm, but it's not used alone. Like this is not the only treatment you would give them. And optimal duration, frequency, intensity is not known. So further studies needed in this one. And then coming to transcutaneous neuromuscular electric stimulations. This is where you give electrical stimuli and leads to contraction of individual muscle bodies. And the best part, minimal cardiopulmonary involvement from the patient themselves. So this bypasses your cognitive or motivational or psychological aspects that prevent a patient from completing their exercise regime. It's appropriate for those who have severe respiratory or cardiac limitations, or they're just deconditioned, and it appears to improve exercise capacity and reduces dyspnea. But there are contraindications such as a pacemaker, defibrillator, seizure history, cardiac arrhythmias, or knee and hip osteoarthritis, or history of joint replacement. But overall, it's generally safe and well tolerated. You can also do Tai Chi. This is where you do slow rhythmic movements in a focused manner with deep breathing to kind of help them slow down their breathing. And then 2 systematic reviews shows that there are some functional capacity improvements and pulmonary function improvements. But again, comparing it to a full exercise regimen, it has been less studied, so you would not recommend this on its own. Other option is whole body vibration. So you get the patient to stand on there and the platform shakes, which causes small mechanical stretches and reflex contractions. So there is significant improvement in functional exercise in these patients. It can be done in acute exacerbation. It also leads to improved postural balance. So you can suggest this for someone who's frail and you're worried about a fall risk, so they can hold and the machine is shaking them. Second component of pulmonary rehab that is done alongside of exercise is patient education. So you can go through everything it is about their disease process, starting from anatomy of their lungs to the physiology of their disease, for the benefits, symptom management, nutrition, travel. All patients should receive education on how to improve their lung disease, and then self-management about what to do about their symptoms at home, so they don't make an appointment in clinic and then you say you could just do this instead. So studies have shown patients instructed about their disease, about various therapies, they understand and recognize their disease better. However, education alone has not shown any benefit. So you can't just do education, forget the exercise part, because for studies comparing education to exercise, there was no significant, there was very little benefit. One of the important aspects is that they teach about long-term oxygen therapy. So it tells them when or what are their indications to get oxygen. So it's for those patients who ultimately will need oxygen but don't know it yet, and the importance of not smoking while on oxygen therapy. And then also the types they have, options available, and the logistics of traveling, which is a big factor for a lot of people. And then other things is like what medication works when, what do you use in exacerbation, what do you use at in the beginning, and how often you use it, how do you use the inhalers and the nebulizers. And then you want to promote healthy behaviors. So you want them to be able to develop their action plan of what to do when they have a certain symptom, or when to seek hospital versus clinic help, and then strategies for symptom control. And then you want to help them identify their triggers and avoid them, and then increase physical activity and help them obtain their vaccines that they may be lacking. Smoking cessation is the most beneficial therapy for any chronic lung disease. And then you want to give them education about the risks, which I'm sure they already know, but you can also refer them to smoking cessation groups within the program itself, give them nicotine replacement therapy. However, true or false, cigarette smoking is an independent predictor of low adherence to PR, which I kind of already given the answer earlier in one of the low attendance. How many people think it's true? So it's true. If they're smoking, they're less likely to attend pulmonary rehab because they'll be told to stop smoking. Other things is nutrition. Risk of obesity is there because they're not exercising, they're getting steroids during the exacerbation. So focusing on weight loss can help further reduce work of breathing. But those who are on the opposite end with advanced lung diseases may be at risk for progressive weight loss and malnutrition. So you want to help them at that spot as well with your nutritionists. And then you have your advanced care planning that is put into the program so patients become more comfortable with discussing these issues. And part of the education is to tell them ultimately where their disease process will lead them. So it's kind of used to designate all their healthcare proxy, provide the family and the patient with clear sense of the goals of treatment or what they prefer for life-sustaining treatment. So that's helpful when the patient is hospitalized later. And then psychological support. So pulmonary rehab, 15 to 20 sessions have been more effective in reducing anxiety for patients with chronic respiratory diseases than similar number of psychotherapies. And then never forget, like chronic respiratory disease is a risk factor for anxiety and depression. So looking at a meta-analysis of 11 studies in 2019, pulmonary rehab had benefits and improvements in both anxiety and depression. And another randomized control trial from an older study showed that even if they don't notice any improvement in their quality of life or the degree of shortness of breath, they still have improvements in their depression scores. So it helps them independent of the benefit they're getting from their exercise and education. So coming to the benefits, there is a possible mortality benefit. One systematic review did not find a statistically significant reduction in 2016, but later a large retrospective cohort study was done in 2020, which showed a strong association between pulmonary rehab and reduced all-cause mortality at 1 year, with an absolute risk difference of negative 6.7%. So more studies are definitely needed to try to figure out if there's a mortality benefit. And again, with the duration and optimal intensity and everything. So further research. Exercise capacity and lung function. So a meta-analysis of 65 trials showed that pulmonary rehab is more effective than just having your community-based follow-ups with the pulmonologist or even the PCP. And then there's improvements with 6-minute walk test that passes the clinical significance threshold, and then improves exercise capacity. And then it has shown that in a 3-year prospective case control study, that's shown improvements in BMI, lung function, and health status as well. So coming to quality of life, any medical intervention now is kind of also being judged by how the patient feels after the intervention. So our studies have looked at that, and then 65 randomized controlled trials, a meta-analysis was done, and it shows there's a minimal clinical difference in all 4 domains, which is fatigue, emotional function, mastery, and the feeling of dyspnea. And then there is a statistically a significant improvement in the domains of a St. George's Respiratory Questionnaire. Frailty. So in one study of 800 COPD patients, 60% of frail patients who completed the pulmonary rehab program, they were no longer frail at the end of the study. Initially, frail patients have more improvements overall, and then the issue is being frail also doubles their chance of not being able to complete the program because they're either exacerbated in the hospital or they can't travel to your program. So that's where the frailty rehab paradox comes in, is that the frail patients are the ones that are most likely to benefit, but less likely to complete the rehab sessions. And then cost. So pulmonary rehab decreases hospitalization, recurrent hospitalization. An average decrease was 23 days per year per patient. And then US Medicare data shows that in the year after the hospitalization, pulmonary rehab results in about saving of $8,000 per patient in 2022. But again, this is one study. You want to look at many other studies, larger groups, to really assess the cost effectiveness of this program. Most of the things I've talked about, all these patients, as you notice, were COPD patients. But what about the other diseases? Do we recommend this for, let's say, someone with asthma, ILD? You already know the benefits for COPD, so let's look into other ones. There was a small chart I found. We're kind of comparing all the reviews, but I'll talk about each one. Interstitial lung diseases. So what is it? It's dyspnea on exertion. They have progressive decline in lung function and high mortality. And then they develop exercise-induced hypoxemia and pulmonary hypertension, which leads to deconditioning and then avoidance of activities. So pulmonary rehab has shown improvement in this disease, but like the benefits are smaller. They only last 6 months, while in COPD it lasts up to 2 years. And then, but it does show improvement in functional status and quality of life. And then you can focus on ILD educational content, so just specialize it for this patient group. Bronchiectasis and cystic fibrosis. Cystic fibrosis, where you have cough, purulent sputum, recurrent infection. There's no specific recommendations for cystic fibrosis, but for bronchiectasis, some small trials have noted some improvements. But of course, higher physical activity is associated with better survival. The one thing with cystic fibrosis is that there's a need to reduce risk of transmission of resistant organisms. So when patients with cystic fibrosis are undergoing pulmonary rehab, they need to maintain a distance of 3 feet from other patients to because of the risk of cross-infection with antibiotic-resistant bacteria. So that's something you want to keep in mind, that you need to have local infection control policies in place. Asthma leads to physical activity avoidance. So undergoing PR improves their symptoms, anxiety, quality of life, and leads to reduced exercise-induced bronchoconstriction. Pulmonary arterial hypertension. So this is a group of disorders where you have persistent elevation in pulmonary vascular resistance, and then that leads to progressive dyspnea and severe activity limitations, and then eventual death due to right heart failure. So the role of exercise is less established in this particular group of patients because there is concerns of syncope and sudden death. So for patients who have pulmonary arterial hypertension, but they have shown good response to targeted medical treatments. You can give them low exercise and lead to exertional improvements in dyspnea. And you can always refer them to pulmonary rehab for the education aspect of things and all the other components other than just exercise. Lung cancer. Many patients with lung cancer are not able to complete the program, but a small duration, if tolerated, is recommended. Lung transplant patients. So pre-transplant pulmonary rehab is suggested to optimize them for surgery and gives the patient a knowledge base about what the surgery will be like, what medications they will need to be on, how to monitor post-surgery, and the complications that they can foresee. And then rehab is usually begun in the first 24 to 48 hours after surgery to optimize the lung expansion and secretion clearance. So long COVID syndrome, you have patients who are experiencing dyspnea, headache, fatigue, weakness, depression, all of this that impairs them from going back to work or doing their daily living. That's the long COVID-19 syndrome. And then initial studies are showing that it may be of benefit. Systematic review has shown some improvements and it helps to lessen disability. And then a prospective study completed in 2022, but again, 36 patients, that's not a big sample size, going over 6-week pulmonary rehab versus no rehab, significant improvements were noted in lung function and 6-minute walk test. So just kind of the summary is in the ATS clinical practice guidelines that was present in 2023. So most of them have strong moderate quality of evidence. So coming to the conclusion, a lot of research is needed. Again, this is from the same ATS guidelines. You want to figure out which disease-specific pulmonary rehab things you want to consider, such as early stage versus late stage COPD, the timing, when to start it, when to end it, and what models, what regimen to put patients on. And again, health outcomes versus cost, all of those things still need further review. But coming back to the discharge order set of COPD discharge order set, you have the pulmonary rehab button. When do you click that? It's when you have patients have a chronic respiratory disease that they're having symptoms related to that disease. How many people are going to click that button now? And then in summary, pulmonary rehab can be initiated at any stage, and the goal is to minimize symptom burden, maximize your performance, give them autonomy that they feel has been taken away, and increase their participation in everyday activities, social activities, and ultimately enhancing their quality of life and improving their long-term health. And then thank you to Dr. Umana and Dr. Mee who helped improve my PowerPoint. Questions?
Thank you, Dr. Khan. If you're viewing online and you have a question or a comment, please enter in the chat and we'll read that for you. If you're in the room and have a question or a comment, we'll ask you to use the microphone.
Thank you, Dr. Khan. Great talk. I kind of wanted to know a little bit more if you ran into any research regarding pulmonary rehab gold stages. If you kind of touched on it briefly, late stage versus early stage, but if you saw any mortality benefit between gold stages.
No, and there's so little research that's available for specifically disease process. I personally didn't come across any that was defined specifically on gold stages. It was more about where they're having, what the degree of impairment is that the patient is feeling.
By the way, I'm Dr. Carrillo. About 15 years ago, more or less, I read a story that it was CoQ10, believe it or not, did help pulmonary function in these patients. But you were talking, and this was done in Japan, but you're talking more or less from 1,200 to 1,600 milligrams. That's mega doses. The other thing I didn't see in this study, how many, no study or anything is complete, but I'm just qualifying it now. They didn't check testosterone levels at this point in time for muscle. The other thing that they needed to do was thyroid function. That's one of the things you needed to do more or less to see, how's the activity of the thyroid, because that comes into the muscles also more than anything else. But testosterone will be number one, no ifs, buts, or why. So that was, I didn't see it in the studies at all, so just bringing it up.
Thank you.
We do have a question from online. And Dr. Khan, is cost or insurance approval a barrier for patients we refer for pulmonary rehab?
Cost is definitely it depends on what chronic respiratory disease they have. Some insurance are more likely to cover for like COPD, ILD, and asthma, less likely for the rare ones. And it kind of depends on the institution. So you just have to talk to your provider, see what is available. But specific ones, I'm not sure.
If it's a pulmonologist order this referral versus we order it, it's gonna be a different coverage where it's better for them to have their primary pulmonologist to do it.
So yes and no, because from what the data shows, even pulmonologists are not using this. So
Okay.
that's why the treatment itself is underused and underfunded. So it makes it expensive for some, but as long as providers are referring it and they make it through all the criterias of they have the PFTs, you figure out if they're going to complete it or not, then they'll take it from there.
Okay, because I was thinking for some treatment or procedure like cardiology rehab, if it's ordered by cardiologists, the insurance tends to cover, and versus PCP, or I'm just wondering it's gonna make a difference, or we.
Yeah. I mean, I didn't come across that. I'm not sure about the answer to that, but yeah.
Thank you. Good talk.
Hey, Dr. Khan, thank you so much for the great talk. My question was, I know you mentioned pulmonary rehab is usually for people who have underlying lung conditions, but has it been tested or shown beneficial for patients who maybe have been on a ventilator for quite a while and get off of it and then are discharged? Have we studied that at all?
So that has been studied and has been more studied with patients COVID survivors, really, who didn't have any lung disease at baseline but were ventilated. But again, the studies are still coming and they're very small, so I didn't make a separate section for them. But yes, improvements noted for them as well.
All right. Thank you, Dr. Khan.